All right, let's talk about the heart, but maybe not the part you think. We're going to dive into the pericardium. That's the protective sac that surrounds it. We're going on a journey, really, from a tiny spark of inflammation all the way to a true cardiac emergency. Getting a grip on this progression is absolutely key for any clinician, so let's hit right into it.
So think about this for a second. You have a patient, they have chest pain, but it's sharp, and it gets better when they lean forward. How on earth does that connect to a situation where their life is on the line? Well, that's the story we're going to unpack today. It's really a domino effect that can happen right there in the space around the heart.
So here's our game plan. We'll kick things off with the spark. That's acute pericarditis. Then we'll see how that can lead to the buildup of fluid, what we call a pericardial effusion. From there, it can get serious with the squeeze, which is cardiac tamponade. We'll also look at the long-term problem, the cage of constrictive pericarditis. And finally, we'll wrap it all up with the response, how we actually manage each of these stages.
All right, first up, acute pericarditis. This is ground zero. It's the initial inflammatory trigger that can really set this whole cascade in motion.
So what are we actually talking about here? Well, at its most basic, acute pericarditis is just inflammation of that pericardial sac. And while there are a ton of things that can cause it, honestly, most of the time we call it idiopathic, meaning we never find the exact cause and just assume it was probably a virus.
So how do you diagnose it? This is huge for any trainee. The diagnosis is clinical. You need at least two of these four things: that classic pericarditic chest pain, hearing a pericardial friction rub on exam, seeing new changes on the ECG, or finding a new or bigger pericardial effusion. Just remember, 2 out of 4 get you the diagnosis.
Okay, let's really focus on the chest pain for a minute, because telling this apart from a heart attack is, well, it's everything. Pericarditis pain is sharp, it's what we call pleuritic, and it's positional. It famously gets worse when the patient lies flat and feels better when they sit up and lean forward. That is a world away from anginal pain, which is usually that crushing, pressure-like pain that comes on with exertion.
What other breadcrumbs can you look for? Well, on exam, you might hear that classic pericardial rub. It's this harsh, scratchy sound. The ECG is also a massive clue. You'll see ST segment elevations, but they're diffuse, all over the place, and concave, kind of like a smiley face. Why diffuse? Because the whole outer surface of the heart is irritated, not just one specific spot like in a heart attack. An echo might show some fluid, but, and this is important, a normal echo doesn't rule it out. And of course, their inflammatory markers, like CRP, will be up.
Now, when that pericardium gets inflamed, it can start to get a little leaky, and that brings us to our next stage, the buildup of fluid, or a pericardial effusion. It's a direct consequence of that initial inflammation.
You know, what's interesting is that many effusions don't cause any symptoms at all. A lot of the time, we just stumble upon them when we're doing imaging for something totally different, and that's exactly why they can fly under the radar until they become a way bigger deal. It's not always about how much fluid there is, but really how fast it accumulates. That's what gets you into trouble.
And the stakes can get pretty high here. If you have a patient with a large effusion that we can't find a cause for, and it's been there for more than 3 months, a startling 1 in 3 of those patients will go on to develop cardiac tamponade. That really drives home why we can't just ignore these incidental findings.
And that progression leads us right to the big one, the squeeze. Cardiac tamponade. We're not just talking about a consequence anymore. This is a full-blown, life-threatening emergency where the clock is ticking.
So what's the actual problem in tamponade? It's really just simple physics. You have too much fluid in a space that doesn't stretch. That fluid starts to squeeze the heart from the outside, and that compression stops the ventricles from filling up with blood properly. And if blood can't get in, well, it can't get pumped out.
When you're examining the patient, you're on the lookout for some classic signs, some of which make up what's called Beck's triad. Their heart will be racing, tachycardic, trying to compensate. When you listen, the heart sounds will be muffled or distant because of all that fluid. And you'll see their neck veins, their JVP, will be elevated. Hypotension, or low blood pressure, that's a really bad sign. It often means you're late to the party.
Now, here's a crucial and kind of cool physical exam finding, pulsus paradoxus. What it is an exaggerated drop in their systolic blood pressure, more than 10 points, every time they take a breath in. It's a sign of just how badly the heart is being squeezed, and it's a massive clue for tamponade.
So how do we lock in the diagnosis? Well, the ECG might show low voltage in all the leads, and maybe this funky thing called electrical alternance, where the QRS complex literally alternates in height as the heart swings around in the fluid. But the definitive test, the money shot, is the echocardiogram. That's where you'll see the classic sign, the right side of the heart actually collapsing in on itself during diastole because it just can't handle the pressure from the outside.
Okay, so we've talked about the acute stuff, but what happens if this inflammation just kind of simmers and leads to chronic scarring? Well, we end up in a totally different situation. This is the cage, constrictive pericarditis, where that flexible sac turns into a hard, rigid shell.
With constriction, the problem isn't acute fluid pressure, it's chronic scarring. The pericardium gets thick, fibrotic. Sometimes it even calcifies. This rigid cage literally stops the heart from expanding like it should to fill with blood. It puts a hard limit on the total cardiac volume.
The physical exam findings for constriction are really unique. You might see something called Kussmaul's sign, where the neck veins actually go up with inspiration. That's the opposite of what should happen. You might also hear a pericardial knock, which is the sharp, early diastolic sound. These are really key findings that point you towards constriction and away from other causes of heart failure.
Now this is a huge one. Telling the difference between constrictive pericarditis and restrictive cardiomyopathy is a classic clinical challenge that trips a lot of people up because they can look really similar. But the key is to ask, where is the problem? In constriction, the heart muscle itself is fine. The problem is the cage outside of it. In restriction, the problem is intrinsic to the heart muscle. The muscle itself is stiff and doesn't relax well. And you have to get this right because the treatments are completely different.
So, we've walked through this whole spectrum, from a spark to a squeeze to a cage. The big question is, what do we do about it? Let's talk about the response. The treatments really run the gamut, from some simple anti-inflammatory pills all the way to major heart surgery. Let's break it down. For a straightforward case of acute pericarditis, we're using anti-inflammatories, things like NSAIDs and a drug called colchicine. For that scary emergency of cardiac tamponade, you have to get the fluid off. Now, that means an urgent pericardiocentesis. And for that chronic, rigid cage of constriction, the only real cure is a surgery called a pericardectomy, where they go in and strip that scarred sac away from the heart.
And that brings us to one last thought to leave you with. Imagine you're standing at the bedside. You've got a patient with clearly elevated neck veins. Based on everything we just covered, what's the one physical exam finding that's going to help you most quickly tell the difference between tamponade and constriction? Really thinking through that is what can make all the difference in a real clinical situation.